Hello, everyone, and welcome to the last respiratory and physical therapy session of the conference. It's probably been a long couple days, and you guys are probably ready to get back to where you came from. So I'm Ginger McPhail, and I'm a respiratory therapist. I work at Cincinnati Children's Hospital, and I have worked in CF for 22 years. And this is Kenneth Wu, and he is a physiotherapist at St. Michael's Hospital in Toronto, and he too has 21 years of experience. I'm sorry, are you guys hearing me? I realize I'm turning my head and looking at him after I told myself to not do that. We wanted to just kind of show you guys how to get to the Q&A session. You guys have probably seen this a few times by now. If you don't feel comfortable submitting questions that way, you can walk up here, we can turn the mic around, and you guys can ask in person.
Yeah, Linda, how do I stop?
I swear we practiced this a couple times.
Okay, so you talk about us.
Yeah, I kind of did.
Yeah, so today's objective is to discuss about the latest research findings on lung clearance index and its current utility for clinical decision making, and on the methods used to evaluate the immediate effect of airway clearance techniques in adults with cystic fibrosis. We're going to examine the current outcomes of patients with CF requiring mechanical ventilations and/or ECMO to identify the key differences between the high-frequency percussive ventilation and conventional mechanical ventilation, and to review the impact on airway clearance and outcomes for patients with cystic fibrosis. And the last objective is to describe the effective of aerobic and resistance exercise training on nutritional status and body composition in cystic fibrosis. So we have a truly international speakers. We have people from Australia and US and also from Canada as well. So I am going to introduce the first speaker. The first speaker is Naomi Chapman. She's from Australia. She's a senior physiotherapist in the pulmonary rehabilitation at Sir Charles Gairdner Hospital in Perth. She's also a PhD candidate from Curtin University in Perth, Australia. So she'll talk to us about the novel analysis of airway clearance techniques in adults with cystic fibrosis. Thank you.
All right, thank you everybody for making it to the last session of the last day today. And yes, thank you very much to the organisers for inviting me to come as well. I can take this off. Sorry, I don't want to ruin my holiday in America by catching COVID. So let's see if this works. No, okay. I'll just use this, that's fine, thank you. Okay. So I have nothing to disclose in relation to this presentation. So today's presentation will consist of an overview of the background of airway clearance techniques in CF, and then I'll discuss the components of the systematic review and meta-analysis that I completed at the beginning of my PhD to try and make sense of the data available on outcomes used to measure the effectiveness of airway clearance techniques in adults with CF. As this area of research has always been very difficult to understand, and we wanted to have a good understanding of the literature and the gaps before we embarked on doing an airway clearance study of our own. I'll then discuss where to from here, which potentially might be a bit controversial from talks we've heard throughout the proceedings so far, and then future research that's related to this systematic review. So as we all know, daily physiotherapy using airway clearance techniques is an integral component of CF management. And in this presentation, we'll define airway clearance techniques as any technique which manipulates lung volumes, gas flow, ventilation, gravity, pulmonary pressures and/or compressive forces with the goal of shearing sputum along the airway lumen towards the mouth. So there are a multitude of different airway clearance techniques available for use. However, there's little evidence to support one of the more commonly used techniques over another. This is due to significant heterogeneity in airway clearance techniques used, as well as how they are prescribed and also how we evaluate the effects of these techniques. So to evaluate the effects of airway clearance techniques, there are the traditional outcomes, such as spirometry using FEV1 and sputum weight, as well as the emerging outcomes such as multiple breath washout and oscillometry. And of course, other measures that are used, such as imaging, lung volumes, and sputum inflammatory biomarkers. Therefore, we conducted a systematic review and meta-analysis to evaluate this area further. So the aims of this systematic review and meta-analysis were to determine in adults with CF what airway clearance techniques have been explored, what outcome measures have been used to evaluate the immediate effects of airway clearance techniques, and then finally to determine what is the evidence for effect of airway clearance techniques immediately following treatment. So for studies to be included in this systematic review, they needed to have applied airway clearance techniques to adults with CF and reported outcomes related to the effectiveness of airway clearance techniques within 60 minutes following treatment. Studies were excluded if they were in languages other than English and only published as abstract or conference proceedings. 5 databases were searched, Covidence software was used to screen for eligibility, and it was pre-registered with Prospero. So in regards to data extraction and analysis, studies were grouped according to study design, and a risk of bias assessment was completed for the randomised control trials and randomised crossover trials using the Cochrane's Risk of Bias Assessment version 2. Initially, we completed a between groups meta-analysis and then a within groups meta-analysis. And lastly, we completed a meta-regression to explore the effects of moderators or factors that may influence the change in different outcomes. The 2 factors we examined were mechanism of action of the airway clearance techniques and also clinical stability of the participants, so being acutely unwell versus clinically stable versus a mixture of both. So moving on to results, here's the Prisma diagram indicating the flow of studies in this review. So 2,048 records were identified, just over 1,500 abstracts were screened, and of these we went on to assess 233 full-text articles for eligibility. 70 studies met our inclusion criteria, unfortunately, and were included in this review, and then 2 studies were excluded from the final analysis as the airway clearance technique mechanism of action could not be determined. So moving on to the characteristics of the 70 included studies, 4% were randomised control trials, 81% were randomised crossover trials, and 14% were other study designs. Just over 1,200 participants were included, with 57% being male, the mean age range being 18 to 36 years, and the mean FEV1 range being 25 to 76% predicted. So firstly, we looked at what airway clearance techniques have been explored. So each airway clearance technique was grouped according to their mechanism of action, and the available groups were as follows. So positive pressure devices, so devices that deliver flow to create positive pressure within the airways during inspiration and or expiration, such as non-invasive ventilation or the MEDANEB. Positive expiratory pressure devices, which are devices which create positive intrinsic pressure within the lungs, or within the airways, during expiration with or without oscillation, such as the PariPep, Arabica, Acapella, and Flutter. Other techniques, which were techniques that did not utilise positive pressure, but required the person to manipulate their breathing pattern to change the flow and or volume beyond the 3rd generation airways, which may be applied with or without external vibration or percussion of the chest wall, such as the vest, autogenic drainage, and percussion and postural drainage. And finally, we use cough alone as the control arm. So this was described as rest with either directed or spontaneous coughs. So 68, as I mentioned, 68 of the 70 studies provided adequate information about the airway clearance techniques used for coding. The most commonly used techniques were those classified as other techniques and positive expiratory pressure devices, which included both oscillatory as well as normal PEP. For interest's sake, a study by Ward and colleagues recently summarised the most common airway clearance techniques utilised by adults with CF in Australia. They recruited from centres that provided data to the Australian Cystic Fibrosis Data Registry, and this study found the most common airway clearance techniques utilised in Australia by adults with CF during unwell and well periods were HUF and PEP. Interestingly, in contrast, data taken from the Cystic Fibrosis Foundation 2020 report showed the primary airway clearance technique utilised in the US by adults with CF was high-frequency chest wall oscillation devices, such as the vest, and secondly, but with much lower numbers, PEP or oscillatory PEP. We then moved on to examine what outcomes are used to evaluate airway clearance techniques. So just to orientate you to this figure, on the y-axis, we have the number of studies, and on the x-axis, we have the types of outcomes used. So the two most frequently reported outcomes were the amount of sputum expectorated, expressed as weight or volume, with this being included in 72% of the studies, and spirometry, in particular FEV1, which was included in 60% of the included studies. This finding aligns with multiple other Cochrane systematic reviews completed in CF. So although we acknowledge there are a range of different ways to evaluate the effectiveness of airway clearance techniques, we are going to focus just on sputum expectoration and spirometry today in regards to the meta-analysis and meta-regression. Now, if you look closely, you can see that the columns have different colours in them, and these different colours represent the different study designs. So black for randomised crossover trials, white for randomised controlled trials, and grey for all other study designs. And as mentioned previously, you can see that there were only 3 randomised controlled trials and a huge number of randomised crossover trials included in this review. So interestingly, when we looked at the airway clearance techniques used in the studies that evaluated the airway clearance technique effectiveness using sputum wet weight, we were able to see how airway clearance techniques have progressed over the years in adults with CF. So just to orientate you, the x-axis we have the year, and the y-axis we have different airway clearance techniques. So funnily enough, it has evolved a little bit like cars. So initially, it's not working. Anyway, initially cars started off as a manual or stick shift transmission, I think it's known as over here, and over the years have moved to more automatic transmission. The same has happened in regards to airway clearance techniques. Airway clearance techniques initially consisted of manual techniques and are now moving to more independent techniques using devices. Postural drainage was first described in 1934, and in the 80s and 90s, gravity-assisted postural drainage and manual techniques, including percussion and vibration, became mainstay care for people with CF to remove tenacious pulmonary secretions. The ketchup bottle technique was described, and they believed that if you tip the lungs upside down and hit them, i.e. percussion, secretions could be removed, a bit like your tomato sauce bottle. So a landmark study in 1984 by Falk et al. Reported percussion caused substantial and prolonged desaturation compared to the use of PEP devices. And in the early to mid-90s, it was confirmed that gravity-assisted drainage positions may be causing harm due to a significant increase in reflux episodes occurring, which led to microaspiration and increased hospital utilisation. These techniques were still quite passive or dependent, and as PEP seemed to be as or if not more effective than manual techniques, airway clearance techniques therapy evolved further. And as you can see on the figure here, the studies evaluating postural drainage and percussion dropped off as people looked to more active independent airway clearance techniques in adults with CF. Then, as we enter the 21st century, more automated devices have been created and researched, such as external oscillation and positive pressure devices. So there was sufficient data from the randomised control trials and randomised crossover trials to conduct a meta-analysis to determine the magnitude of between-group change for the outcome sputum expectoration. When we compared PEP devices to cough alone, there was no between-group difference for wet or dry weight sputum, as shown by the mean difference and a 95% confidence interval on the screen. When we compared other techniques to cough alone, again, there was no between-group differences, as you can see by the mean differences and confidence intervals. There was also sufficient data from randomised control trials to conduct a meta-analysis to determine the magnitude of between-group change for the outcome FEV1 in litres. As shown by the mean difference and 95% confidence interval on display, there was also no between-group change differences for this outcome. So I guess here's getting a little bit contentious, I guess, where you come from. But there was considerable methodological heterogeneity and high risk of bias across the studies, as we expected, which limited our ability to perform an in-depth meta-analysis of between-group differences, which reduced the certainty of our results. Going forward, the usual recommendation would be to perform more robust randomised control trials to evaluate the effects of airway clearance techniques. However, I'm not sure how it is in the US or the UK, but in Australia, these randomised control trials comparing airway clearance techniques to no therapy are not possible, as it is now considered unethical to withhold airway clearance techniques from anyone with CF. This is why we came up with the idea to use a novel approach to analyse the data using within-group differences and meta-regression to determine the moderators of change. While we understand this is not as scientifically robust as evaluating between-group changes, we decided that this was the most pragmatic option to make sense of the data. So initially we looked at the magnitude of within-group changes using expectorated sputum wet weight. So firstly, just to orientate you to this figure, we have the individual interventions from different studies on the y-axis and sputum wet weight in grams on the x-axis. The data presented are mean and standard deviations, and the black line represents no effect or change. We found that the magnitude of the overall pooled effect of sputum wet weight was 12.4 grams post-airway clearance technique treatment, as indicated by the yellow line, and the 95% confidence intervals are indicated by the blue shaded area. As you can see, there is a lot of variability in the estimates and the precision of the estimates, showing significant variability over the different interventions, meaning these results need to be interpreted with caution. Currently, there's no known minimally clinically important difference for sputum wet weight in adults with CF. However, a reduction of 6.4 grams of sputum over 24 hours post-airway clearance techniques has been proposed as the MCID in adults with non-CF related bronchiectasis, nearly half that of the change that is indicated here. When we completed the meta-regression to explore the moderators or factors that influence the change. So we found that all airway clearance techniques, no matter their mechanism of action, had a greater effect on sputum wet weight than cough alone. Again, we understand this is not as robust as between-group meta-analysis. However, it does provide some evidence that airway clearance techniques as a whole, when grouped as positive pressure devices, positive expiratory pressure devices, and other techniques, produced a higher amount of wet weight sputum compared with cough alone, indicating the time-consuming, burdensome airway clearance techniques we get adults with CF to complete are having an impact and are more effective than just coughing alone. In regards to participants' clinical stability, the estimate of the effect of airway clearance technique on sputum wet weight was not moderated by this. We then moved on to look at the magnitude of within-group changes measured using FEV1. Once again, orientation to the figure is the same as previous, except now we have mean change in FEV1 in litres on the x-axis. The overall pooled effect of FEV1 was 0.03 litres, indicated by the yellow line, with the 95% confidence interval indicated by the blue shaded area. This indicates minimal to no change in this measure post-airway clearance techniques. When FEV1 was measured as a percent predicted, the pooled effect was 1.44% percent predicted, as indicated by the yellow line. Once again, the 95% confidence interval is indicated by the blue shaded area. There is a lot of variability within the standard deviations, however minimal around the mean effect, indicating FEV1 measured as a percent predicted is unlikely to change immediately post-airway clearance techniques. While this change was statistically significant, it is unlikely to be clinically significant when treating, a clinically significant change when treating adults with CF. Once again, we looked at the moderators or factors of change of FEV1, and as expected, the mechanism of action of airway clearance techniques or the participants' clinical stability did not alter the effects. So I guess the take-home message, there is some evidence when evaluating within group differences that within 60 minutes post-airway clearance techniques, sputum wet weight seems to increase, and it increases more with airway clearance techniques than cough alone. However, there is little rationale for the use of spirometry, in particular FEV1, to evaluate the immediate effects of airway clearance techniques, as it doesn't seem to change within 60 minutes post-treatment, despite it being the main clinical endpoint used by regulatory bodies in CF research. So in conclusion, the area of choosing the most appropriate airway clearance technique and outcomes to measure their effectiveness is a challenging area for clinicians to interpret due to a number of different reasons, including the limited amount of randomised control trials available in this area, and of those that are available, there is significant methodological heterogeneity and high risk of bias of these studies. And finally, there are huge limitations in the reporting of data, with 61% of the included studies published prior to 2010 when the consort statement was published, and 73% published prior to 2014 when the TARDIA checklist was released. Both of these were introduced to ensure transparent and complete reporting of randomised controlled trials and their interventions. However, as previously mentioned, this is unlikely to change in the future due to the ethical considerations surrounding withholding airway clearance techniques from adults with CF. However, may change with the introduction of these highly effective modulators. So where to from here? There needs to be more consistent and accurate reporting of further studies, which can be improved by prospective registration of randomised controlled trials so that the primary aims are predefined, more consistent and accurate reporting of methodology and results as per the 2010 consort statement, and detailed description of interventions as indicated by the TARDIA checklist. Also, further research is needed to evaluate the immediate effects of airway clearance techniques in adults with CF using novel, reliable and responsive measures that only require tidal breathing, such as multiple breath washout, oscillometry and emerging MRI modalities. So where to from here? In regards to further research in this area, after completing this systematic review, we decided to do exactly what we recommended, and that is undertake studies evaluating airway clearance techniques in adults with stable CF and in adults admitted to hospital with an acute exacerbation of CF, using novel outcomes that require only tidal breathing, including functional MRI, multiple breath washout, and oscillometry. Another consideration in this area for further research is the impact of the highly effective gene modulator therapies such as Trikafta on adults with CF and how this will change the way we are measuring the effectiveness of airway clearance techniques. So throughout my PhD, we have collaborated with a number of different organisations and people, and I'd like to acknowledge each one of them for their ongoing support. Thank you very much.
Do we have any questions?
You have one? Okay.
You mentioned about 60 minutes after the physiotherapy. What do you do clinically? I find that after doing the chest physiotherapy for patients, they say to me afterward they walk around and then they started coughing up a lot of phlegm. Is that what you guys do as well in Australia or in your clinic?
Yes, so a similar sort of thing. And I guess that's why we pushed it out to 60 minutes post-airway clearance treatment, because we do know that people do report that they don't immediately expectorate after their treatment, but potentially for an hour or hours afterwards. But we kind of had to cut it somewhere. So, yeah.
So I have a question as well. So are your patients doing inhaled meds along with the airway clearance?
Yes. Yeah. So we try to incorporate it, well, with the Arabica or the PEP, Pari-PEP, we try to incorporate the nebulizer to reduce treatment burden and time. So.
I have one more question. Okay. So when you look at the studies, you mentioned about you group them by the mechanism of the action. But why don't you separate, like, for example, PEP and oscillating PEP? Why don't you separate them so they look at the differences between them?
Yeah, so because there were not enough studies, basically. So to do a robust meta-analysis, we kind of had a cut-off for how many studies needed to be included in that group to actually be able to get some data from it. So, if we had split it up any more, then we wouldn't have had enough studies within the groups to do the meta-analysis.
Okay. All right.
We understand that's, it's not ideal, obviously,
Right.
and we potentially could have split the other techniques up a little bit more different, but that's what we did. And yeah, that is one of the limitations, I guess.
I have one here that was just sent. From your work, do you foresee any better outcome measures to use?
Well, initially, we would say hopefully lung clearance index, maybe oscillometry, and the MRI modalities. However, the results from some UK studies obviously have showed that lung clearance index potentially in adults is not effective in or responsive to measuring the effects of airway clearance techniques, at least immediately. In the study that we are doing in inpatients is looking at, as I mentioned, lung clearance index and FOT oscillometry within over 6 days of admission. So we have a little bit more longitudinal data. And we've also done a study looking at the MRI modalities and looking to see if we can see any changes in sputum expectorated or changes within the lungs. That we have not yet analysed that data, however. So.
Any more questions?
Cool.
Okay.
All right, thank you
Thank
very
you,
much.
Naomi. Okay, our next speaker is Dr. Joel Murmas. Dr. Joel Murmas is an associate professor of medicine and a director of the Cystic Fibrosis Center at the University of Kansas Medical Center. Dr. Murmas is going to present to us mechanical ventilation in cystic fibrosis and the evidence for use of high-frequency percussive ventilation to augment airway clearance in an acute respiratory failure. Please welcome Joel.
I can't get to yeah. Where's the cursor?
Our IT is gone. Can this thing do anything?
Is this a mouse?
Sorry, our IT guy stepped out. We might need him. Oh, there it is. Why is it on this?
I don't know, it's not on the monitor.
It's not on the monitor, though.
Well, let's see if it's,
Yeah, no.
Oh, well, thank you.
and it won't work.
Can you just hit escape and try to do it again? No.
Yeah, it's not working there either. The usual method, shut it down and restart it. Maybe that's a bad idea.
He told us when we were in trouble, hit escape, and that's not even working.
Oh, really?
So,
Okay. Yeah, and even putting it over, it's not working. Yeah, I'm not a optimistic without some support. Well, is there a way to, did he just leave?
I know he told us he was doing several sessions,
Oh,
but he
really?
would keep circling back around, so.
Okay.
That's so weird. Oh, wait a minute. I think,
Oh, wait, what'd you do?
wait, I don't know. I just kept wiggling.
Oh, you got
Oh, yeah, I think we got it.
Wow.
All right.
You don't know how, but it worked out.
Oh, I didn't, I picked the wrong one. How did that happen?
We can just exit.
No, I think we do the end slide up here. Okay, I thought I clicked his name, and then I thought
You're the best.
no.
Ah,
There it is.
all right.
We got it. Thank you, though.
Okay. Was this working? All right. Well, we're back on. Okay. So my name is Joel Murmas. As mentioned, I'm the Adult CF Program Director at the University of Kansas Medical Center, and I appreciate the opportunity today to talk about our case series of patients receiving high-frequency percussive ventilation to augment airway clearance and acute respiratory failure in CF. Oh boy, what did I do? There we go. Okay. All right, I have no disclosures related to this presentation. We've already gone over the objectives, so we're going to talk about high-frequency percussive ventilation, and prior to doing so, we're going to talk about current uses of invasive mechanical ventilation and in the modern era of all the modalities we have in the ICU, use of ECMO as well, and what is the data and outcomes for people with CF that we currently understand, and what guidelines do we have to guide us in choice of those different modalities. So I want to start with a case presentation of the patient who really inspired our project. This is a 30-year-old gentleman with acute respiratory failure and advanced CF lung disease. He's 30 years old. He has a very advanced CF lung disease with an FEV1 of 19% of predicted. He has chronic respiratory failure and was on 3 liters of oxygen at the time. He had chronic lung infection and was chronically infected with Pseudomonas and Burkholderia sinusopatia. And he was admitted to the hospital for treatment of a pulmonary exacerbation. And unfortunately, on the 3rd day of his hospital stay, he had very resistant organisms, as is often the case with Burkholderia, as many of you know. And despite our best efforts on the ward, his disease progressed to the point where he was rapid responded for progressive respiratory failure. So at this point in this particular patient, what are our options? What are our next steps? And how do we approach this? Obviously, historically, a very controversial topic in this particular patient and a difficult one. In this patient who, because of his Burkholderia infection, the decision had been made jointly between him and transplant staff that he was not going to proceed with lung transplantation. And so in this circumstance, we're dealt with a difficult situation where we need to work with the patient and family to determine what is the best step forward. And obviously this pro-con debate published in 2010 in the Journal of the Royal Society of Medicine really highlights the difficulty of this decision. Fortunately, we do have the recent publication of the CF Foundation Consensus Guidelines for the care of individuals with advanced CF lung disease. And I want to highlight those as they do actually make some reference to how we should approach this particular patient. The guidelines recommend that individuals with advanced CF lung disease with acute respiratory failure be considered eligible for the ICU, management in the ICU, regardless of their transplant status, if congruent with their goals of care. And I think regardless of transplant status is important. And importantly, the guidelines go on to mention that especially for those with non-reversible conditions, which I would argue is the situation for our patient, careful discussion must occur between the patient, the families, their healthcare teams, is needed, particularly for patients on mechanical ventilation, and particularly when lung transplant is not an option, to determine what the best path forward is. And what factors do we really need to consider in this conversation? What are all the things we need to take into account about how we're going to proceed for this patient? So obviously, patient goals are paramount. As we discussed, is this patient a transplant candidate? Do we have a reversible cause? I think that's really important to think about. Is there something we can fix, such as a pneumothorax, where placement of a chest tube may quickly reverse the cause of the decompensation? Or does the patient have hemoptysis, where a bronchial artery embolization might potentially reverse course? Or is this, as unfortunately in this case, really progression of acute on chronic disease, where we know with invasive mechanical ventilation, the progress is likely going to be, the care is likely going to be difficult once the patient ends up on invasive mechanical ventilation. And what local resources do you have? Did the patient present at an outside access hospital emergency room, potentially, where they don't have all the resources you may have in your ICU at an academic medical center? Does your center have ECMO? Do you have high-frequency percussive ventilation? And we're going to talk more about that. And are you at a CF center that happens to also be a lung transplant center, which is important for us to remember is not the case for most CF centers. So in looking at these guidelines, what evidence do we have to guide us on how patients do after we proceed with invasive mechanical ventilation and cystic fibrosis? And there is some data to guide us. This publication reports on the Texas inpatient public use data and reports on over 1,200 ICU admissions. So 13% of hospitalizations in this cohort resulted in ICU admission. And of those ICU admissions, 17% of patients went on to require invasive mechanical ventilation. And this resulted in a mortality rate of 41.8%. Importantly, predictors of mortality were a higher age and being female and having comorbid disease. And while mortality at 41.8% is certainly intimidating to look at, we have to remember that that means 58% of people actually survived to ICU discharge. There was an additional study published more recently in 2019 looking at the 2002 to 2014 U.S. cost and utilization database, examining over 762 CF hospitalizations requiring invasive mechanical ventilation. And in this cohort, similarly, the mortality rate was similar at 44.5%. And also similarly, factors affecting mortality were being female, having other end organ issues, particularly renal failure, and also prior to admission having malnutrition. I think it's really important for us when we're talking about use of invasive mechanical ventilation to at least have a brief discussion of ECMO and what the data is for ECMO, what limited data we have for ECMO and cystic fibrosis. The new CF Foundation consensus guidelines do make a comment on this and recommend that individuals with advanced CF lung disease who develop refractory respiratory failure requiring invasive mechanical ventilation be considered for early transition to ECMO if this is congruent with goals of care. So what data do we have to guide this recommendation? If we look at the ELSO registry data of people with CF and look at survival for those patients placed on ECMO, we find that 38 out of 73 patients survived who were placed on ECMO. The problem with this registry is it doesn't really give us any insight into their course after ECMO was discontinued. Did they go on to transplantation? What was their exit strategy for getting off ECMO? We do have a recent publication just earlier this year in the Journal of CF reporting on invasive mechanical ventilation versus ECMO plus invasive mechanical ventilation for adults with CF. And this study, retrospective, but did report that outcomes were very similar for people who were on invasive mechanical ventilation versus those who received invasive mechanical ventilation plus ECMO. Noting in this modern era, it's hard to know, but they didn't report people on highly effective modulators, but note that the outcomes were a little bit better in this study as far as survival. Of those who went on ECMO, 62% went on to be transplanted. This is retrospective and does call into question where people may have more likely been selected for ECMO because they were known to be transplant candidates. So I think caution is advised on how to exactly interpret that data. For patients who do receive ECMO, how effective is this at bridging to transplantation? We have limited data, but we do have some of this retrospective analysis of 121 adults on ECMO. 39 of these adults had CF, and of those, 27 were bridged successfully to transplantation, so 69%. And this is slightly more effective than we see in the whole cohort as a whole. So this trends toward suggesting that maybe people with CF may fare better on bridging to transplantation with ECMO than patients with other advanced CF lung disease, but this did not meet statistical significance in this small cohort. Importantly, we see that ambulation on ECMO is very important and really was the biggest predictor of success in bridging to transplantation, is maintenance of that, prevention of the deconditioning, which we know is critical around the transplant period. For patients who do go on ECMO, what impact does this have following lung transplantation? Does this have any bearing on people's survival after lung transplantation? We do have a few studies that comment on this, very limited data. So these two studies combined report on 17 people and compare their outcomes to a similar matched cohort who did not receive ECMO prior to lung transplantation, and would suggest that outcomes are similar between the two groups, meaning that if you received ECMO during that pre-lung transplant period, it wasn't an indication of worse outcomes if you had CF. There is some suggestion in other diseases that may not necessarily be the case. So back to our patient. We have this data now. How do we use the data and understanding of what went into these guidelines to manage this patient? What are our next steps in care? Well, at our center, as may be the case for many of yours, we are not a lung transplant center, and while we have ECMO, admittedly, we don't have a great deal of experience of use of ECMO in CF patients. And if a patient does go on ECMO who's not a transplant candidate, what is going to be our strategy to get that patient off ECMO if potentially their lungs don't improve? And this obviously can create a real complex situation. So in this individual's situation, the decision was made to go ahead and proceed with invasive mechanical ventilation. That was obviously after extensive discussion with the patient and his guidance that he wanted to do so. We opted to go ahead and proceed with high-frequency percussive ventilation because of our clinical experience with high-frequency percussive ventilation in the past. And so I want to take a second to talk about that. The current ventilator on the market that's available is the VDR4, which is the ventilator we use at our center. So it is a pneumatic, pressure-driven, limited and time cycled. It delivers high-frequency pulses of gas at a minimum of 60 pulses per minute and up to 720 pulses per minute. These pulses stack to form a low tidal frequency volume. Essentially, you can think of it as a tidal volume until an oscillatory plateau is reached. At end inspiration, the lung empties, and then passively this facilitates airway clearance. An important aspect of high-frequency percussive ventilation is that you can proceed with ventilation with the cuff down, which in our experience has been very important as far as it augmenting airway clearance. It is important if you proceed with cuff deflation that you monitor the peak inspiratory pressure, as it may decline some, and you need to monitor for that. And also it's important to monitor, this could have an impact on oxygenation if there's any excess gas leak because of the cuff deflation. So how does high-frequency percussive ventilation potentially augment airway clearance? Well, the percussive high-rate mini bursts of subtidal volumes travel down the center of the airways, and because this is the path of least resistance, exhaled gas then travels in a countercurrent path along the inside walls of the airways, creating a pulsatile countercurrent. And this has been demonstrated in many airway models to be the case. And in patients with extensive mucus, you could see how this would facilitate the migration of mucus out of the lungs and actually can be facilitated on the outside of the endotracheal tube instead of the inside of the endotracheal tube with the cuff down. This is what the high-frequency percussive ventilation monitor looks like, and there are some aspects of it that are similar to conventional mechanical ventilation. You can set a PEEP. You can set a peak inspiratory pressure. You will set what's called a convective rate, as you can see here, which is essentially functionally your respiratory rate. This is established by setting an I and an E time. And then you can set the percussive rate, which is your rapid pulses. In figure C on the right here, you can see the pulses generating the tidal volume, and then the passive exhalation, and then the beginning of a new breath is demonstrated by the arrow in figure C. So what data do we have to guide us on the use of high-frequency percussive ventilation in CF? Well, not much, unfortunately. But we do have a fair amount of data in burn and inhalational injury that high-frequency percussive ventilation can be effective, and it makes good sense that this may extrapolate to people with CF, because we know in burn injuries, patients have significant airway sloughing and retained secretions that can be significant and problematic. And there is a number of publications demonstrating benefit of high-frequency percussive ventilation in an inhalational injury. And as shown here in this table, actually some studies suggesting a mortality benefit in people who receive high-frequency percussive ventilation as opposed to conventional mechanical ventilation. So to the data we have in CF, and really the motivation for our project, there really is very limited data. When we went to review the literature, we found one case report from 2010 of use of high-frequency percussive ventilation published by the group at St. Louis University, reporting on a 28-year-old patient with an FEV1 of 18%. And they described a significant improvement in airway clearance, which has been our experience, and improvement in the P to F ratio hours after the patient was changed to conventional or to high-frequency percussive ventilation from conventional ventilation, and also improvement radiographically in their X-ray, as shown here in A prior to the change, and then in B after, with some clearing of inspissated secretions. So to our project, so we sought out to do what we could to add it to this body of literature, and here's our case description of our patient series at our center. We reviewed our cases from 2010 to 2019. There were 11 ICU admissions using high-frequency percussive ventilation. The mean duration of time on high-frequency percussive ventilation was 4 days amongst all patients. The median time for patients who survived was obviously less at 2.5 days. The mean FEV1 was 29% of predicted. There were 6 patients in the cohort who survived, and those who did survive, not surprisingly, had higher baseline FEV1 and were younger in age. If you look at the graphic on the right, if that doesn't show up very well, I apologize, but it's a description of all the patients and a little bit about their clinical course. And in the left lower hand graphic, you can see the FEV1 in green at baseline, that's 6 months prior, and then the FEV1 following their ICU stay prior to discharge, and then in yellow, their FEV1 at clinic follow-up. One notable thing that I think is interesting, and it's hard obviously to make or to draw any significant conclusions on 11 patients, but one notable thing is that you see 3 of the patients actually had a higher FEV1 at discharge than their baseline in the 6 months preceding. And this was notable in the case, this was very notable in the case of the patient we've gone through here. And we were really struck by this. So he had actually just after ICU discharge, once spirometry was able to be completed, he had his highest FEV1 he had had in 3 years. And here's probably overkill, but representation of his spirometry in the preceding year. All of his spirometry he had done in the preceding year demonstrated he hadn't come anywhere close to what he achieved in the hospital after being on high-frequency percussive ventilation. You can see the X-ray before and then the X-ray in the hospital after discharge from the ICU. Admittedly, there's some difference in penetration there as portable films, but it does, I think you can definitely see there's improvement in retained secretions. And we can definitely say an anecdotal comment, but in some of these patients within the hours of going on high-frequency percussive ventilation, you can see marked secretions pouring out. It's often quite impressive. So in conclusion, the majority of adults with CF will survive an ICU stay with invasive mechanical ventilation. Importantly, this is in the pre-highly effective modulator therapy era. How do highly effective modulators affect this? One would hope outcomes would even be better, but we don't know this. Early transition to ECMO should be considered per the guidelines, and I think obviously patient conversation and what center you're at, what resources do you have all weigh into this decision. The benefits of this obviously are that if a patient can be awake and ambulating prior to transplant, that's obviously a significant benefit to long-term outcomes post-transplant. For high-frequency percussive ventilation, it does provide ventilation and potentially facilitate airway clearance, unlike we see with conventional mechanical ventilation when a patient has failed non-invasive positive pressure ventilation or high flow, which is obviously what we would do until that was no longer effective. This may transiently improve lung function, as we saw in our patient, but obviously we can't draw unfortunately, any substantial conclusions. But I think it's important to know high-frequency percussive ventilation is out there and maybe an option at your center for certain patients, depending on the resources you have available at your center. The impact on ICU and long-term survival obviously ideally merits further study. And with that, I'm happy to take any questions.
Okay, we have a few here for you.
Okay.
So the first one I have is, can inhalation therapy be delivered on
Yeah.
PPV?
On- yeah,
that's what we
it-
have on here, yeah.
So you can nebulize medications. It can be done hooked up into the circuit, similar to what you would do with conventional mechanical ventilation.
Okay, your next one is HFPV. I can't even see, I should have brought glasses. I'm like
No, it's okay.
holding this back. Therapy be delivered on HFPV? No, wait a minute, I skipped it. I'm reading the same thing, sorry. Can the setting you change for a certain amount of AC, or is it stable setting that they stay on?
Yeah, so they're actually, and I have referenced it and go back just as a resource if people are interested in learning a lot more about high-frequency percussive ventilation. This reference right here, actually has a nice algorithm of how to approach patients depending on their P to F ratio, similar to what you would see like in the ARDS and ET trial, and how you would escalate the settings on HFPV for patients depending on the severity of their respiratory failure. Hopefully I'm answering the question, but you definitely can adjust the settings depending on the severity of hypoxemia as you would with conventional mechanical ventilation.
Okay, and one more. From your work, do you foresee any better outcome measures to use?
That's the previous one.
Oh, that was for the last talk, I think.
Oh, yeah, I'm sorry. All right, I have a question that says, what type of settings did you use on IPV?
On the high frequency percussive ventilation, or on IPV?
So Dabney's in here. I know Dabney,
Sure.
I don't see her.
Oh, so, yeah. You know, yeah, so we often will have, so as on the ventilator, it's the percussive rate, which is your pulsatile, your high frequency pulses will often use a higher pulsatile flow, which theoretically should increase that countercurrent, and then start with a higher pulsatile, higher frequency, in the 500 to 600 range, and then dial that down. As you're getting secretions out, you're seeing less secretions, basically trying to wean the patient from the ventilator. And then our approach, which, I don't really know honestly if it's the right approach, but usually before extubation, then we'll switch the person back to conventional mechanical ventilation, do a spontaneous breathing trial in a fashion that we're all kind of comfortable with before we determine whether someone's safe for extubation. So I think this is really just short-term to try and really facilitate airway clearance where you can't with conventional mechanical ventilation by creating that countercurrent as we reviewed, and then trying to transition, assuming they improve, trying to transition back to conventional mechanical ventilation once you think their secretions are really dramatically improved.
Did that answer it? All right.
RTs still work with other airway clearance while they're on the oscillator, or are they sort of hands on the ground?
Yeah, there's, as far as specific like airway clearance on high frequency percussive ventilation, additional airway clearance techniques, there's, in my experience, not much you can do. You mostly just kind of let the ventilator do its airway clearance, because the patients typically while on this require a fair degree of sedation. If they can breathe independently on top of this, but that sometimes can achieve higher airway pressures than we're comfortable with. So to suppress that, patients will often be quite sedated, and other airway clearance techniques usually are something we wait until they're back on conventional mechanical ventilation or activated. But I will say we do find, in these scenarios, the airway clearance is much more effective with this than trying to do airway clearance through an endotracheal tube with conventional mechanical ventilation, which can be quite difficult. So.
Okay, does the patient typically stay on HFPV for several hours or 20 to 30 minutes at a time?
Our approach usually would be to leave the person on until we feel like they're better. And oftentimes these are situations where, with conventional mechanical ventilation, they're failing. And we're, I don't want to say necessarily salvage therapy. I think we've become comfortable enough with this in certain scenarios where we'll do it early in their course after intubation to try and clear secretions. But essentially the answer is as long as it takes till you feel like they're nearing being able to liberate from the ventilator, at which point we transition back to conventional mechanical ventilation. At least that's our approach. I think there are centers who will wean straight off of this by dialing down the percussive rate and the frequency, similar to you would do with conventional mechanical ventilation. There's just not a lot of data on exactly how to do that, so we usually switch back to conventional first. But like I said, our mean time on for patients who survive was 2.5 days. So.
Okay, one more. Could you comment on how HFPV would compare to ACT devices such as the Metaneb, and would that be an option for them at discharge?
I'm not sure how to answer that.
Yeah, you're providing the same, you're providing the level of heat, and you have the oscillation, so you would just lean it back on the normal airway clearance once they were activated.
Yeah. I guess I wasn't entirely sure of the question, but yeah, obviously this is just for patients with acute respiratory failure in the ICU is the only scenario where we would use this, but.
Any more questions?
I know your conclusion at the end of your case series, which was great. What you were saying further studies would obviously be needed to validate the use of this over conventional mechanical ventilation, but just for you as a clinician, will this be your default moving forward at your center when you have those patients intubated?
There are challenges with this that actually have been impacted by highly effective modulators. We have a lot less people in the ICU now, which is awesome. But it does require ongoing annual RT training to make sure the RTs have enough experience with high-frequency percussive ventilation that they're comfortable using it. And when these cases come up now so infrequently compared to how often they used to, that does present a challenge. I think we've definitely seen enough benefit in the past where we want to make sure we have this as an option for people who aren't improving with other techniques who require invasive mechanical ventilation.
And do you see a benefit in the removal of CO2 for those patients that have severe ventilatory failure when they're putting the cuff down too, similar to what we see
You definitely can see that in some people, that can improve hypercapnia and improve ventilation, particularly as you're helping with the clearance of a lot of secretions. That improves ventilation as well, but yes.
We got one more.
Okay. Yeah, it's variable, but in general, I would say more likely. It's just not a natural physiologic phenomenon, so people generally, I think, do require more sedation. Yeah.
All right, thank you.
So next speaker is Dr. John Lohman. He's a board-certified cardiovascular and pulmonary clinical specialist and associate professor and director of residency education in the Department of Physical Therapy, Outpatient Physiotherapy, UABCF Clinic, and University of Alabama at Birmingham. So he's going to tell us about is exercise detrimental to nutritional status in cystic fibrosis? Thank
you. Well, thanks for everybody for hanging out at the last session, last day, and thanks for the invitation by the moderators here. I don't think my talk's going to be quite as interesting as the last talk. So let's get started here. The only I have no conflicts, but the CF Foundation has kind of provided some funding for me to kind of do this work as part of my work in the CF clinic. Here's our kind of outline of the paper that we kind of published earlier this year, and I guess I kind of jumped over that. So the paper will be presenting effects of exercise on nutritional status in people with cystic fibrosis. So this was a systematic review, kind of a planned meta-analysis, but that kind of got dropped due to a lot of the heterogeneity of our results. So kind of moving on from there. So we all know that CFTR dysfunction occurs not only in the lungs, but in particular in the GI system as well. And so that leads to malabsorption, malnutrition, things that are common in cystic fibrosis. And I will say that we started this project really as a result of patients in the clinic that were reluctant to exercise. This was kind of modulator therapy, so this kind of project got started a couple years ago before a lot of our patients were on modulators and they were underweight and they were concerned that if they started exercising, they would lose weight. And, hey, my BMI is only 18, 19, 20. I don't want to exercise. I don't exercise because I don't want to lose weight. And so that's really kind of what prompted this. And so now we know with these highly effective modulator therapies that CFTR is in the GI system, and when you fix it, you fix a lot of the malabsorption. So the project might be a little bit dated, but we've seen some great progress over the last few years. And so we do know that BMI predicts mortality in cystic fibrosis, and so we don't want our patients losing weight and having a lower BMI. Also, we know that peak aerobic capacity is one of the best predictors of mortality in cystic fibrosis. And, these two can be a little bit competing because how do you improve your peak aerobic capacity? Well, you exercise. With exercise, you also increase your energy expenditure. So as you increase your energy expenditure, there's the risk of losing weight. And so there's this conflict, perhaps, between BMI, trying to maintain BMI and improve energy expenditure. So that was kind of what got this project started. So our kind of PICO question was, does exercise and physical activity affect the nutritional status in children and adults with cystic fibrosis? So similar to the similar methodology to our previous, our first presenter for the day. So our project was registered in Prospero. We searched kind of multiple databases with the help of a medical librarian, using basically cystic fibrosis and body composition, body mass, BMI as our kind of key indicators. These studies were imported into Covidence, where we screened them out by titles and abstracts, then full text, extracted the data into Excel, and also did a kind of a quality assessment. And just a little bit more kind of breakdown of our PICO question and inclusion criteria. So we were looking for children and adults with cystic fibrosis, kind of regardless of their nutritional status. We did exclude under 5 years old. The intervention had to be some kind of active exercise or physical activity. There needed to be a comparison group that wasn't doing any exercise. And really any kind of outcome of anthropometric measurement. So whether it was body mass index, fat-free mass, some type of body composition measurement had to be included in the outcome measure. and we were looking for just randomized controlled trials. So we had, thank God, we didn't have 70 trials to look at, but we only ended up with 4. So we did start off with 924, ended up with 4 studies. And in these 4 studies, they were all children. So we didn't have any adult studies that made it through our filter. And so you can see here kind of a summary of the associated studies that we had. Kind of mean age about 12 between the 4 studies. Body mass index, was typically and body mass was on the low side for the most part. FEV1 kind of ranged from 57 up to 98%. And we will, so we had a kind of a wide range there. So just to kind of discuss some of the interventions for each of these studies. So Salvadori had 3 groups. So he had a aerobic training group, a resistance training group, and a control group. The aerobic training was kind of a moderately high kind of intensity and aerobic intervention for 30 minutes a day, 5 days a week. And this was just for 2 to 3 weeks. So this is really important kind of consideration when we look at the outcomes of this study. This was just while the patient was in the hospital. So this was during an acute exacerbation. So he had folks kind of exercising at a pretty high level while they were sick, while they were in the hospital, doing aerobic exercise. And they did receive supplemental oxygen as needed. Another group did resistance training, 5 to 10 repetitions, 5 days a week. So one day upper extremities, the next day kind of lower extremities. And then there was a control group that did no exercise. Santos Sosa in 2012 did an 8-week study of both aerobic and resistance training. So the exercise group received both aerobic exercise and resistance training, kind of on alternate days. Again, they were kind of a pretty high, moderately high exercise intensity for 20 to 40 minutes a day, 3 days a week. And then on alternate days, resistance training at a fairly similar prescription as in the Salvadori study, 3 circuits of 12 to 15 repetitions at about the kind of 15 repetition max exercise. And the control group just got chest PT and verbal instructions on the benefits of physical activity. They followed up that study a couple years later with kind of the same exercise intervention, but they also added in inspiratory muscle training. So just like you can do resistance training for peripheral muscles, they use the Power Breathe threshold device for inspiratory muscle training. And so that was kind of added in. And the control group in this case did a sham intervention. So they did they used the Power Breathe device, but a very low intensity, one that would not be expected to have any positive results. And then lastly, Homerding in 2015 had a home-based intervention for 3 months. This included kind of aerobic exercise at really a self-selected intervention, whatever they kind of were most interested in doing in terms of the intervention. The kind of limitation here was that they didn't give any kind of intensity. So we're not sure how intense the folks were working. Was this kind of a light intensity? Was it moderate? Was it high intensity? And they did this at least 2 days a week and for 20 minutes. And so, you'll see kind of compared to the other previous 3 studies, kind of the dose of exercise in this particular trial was probably the lowest and the less descriptive. So what kind of outcomes did we find? And so we're going to kind of hit those 4, summary of those 4 studies again. In the Salvadori had looked at body mass. And so body mass over the course of an intervention. So again, in this particular study, folks were in the hospital for an exacerbation. And so all 3 groups, the aerobic, resistance, and control group, all had an increase in body mass during the course of their hospitalization. But you'll notice that the resistance training group had a almost 2 to 3 times increase, higher weight gain compared to the other 2 groups. And in particular, it looks like this was a change in fat-free mass. So they used, so they were also looking at fat-free mass. And so again, this was about a 4-fold increase in fat-free mass, even during the short period of time during the hospitalization. The aerobic exercise group had a significant improvement in peak VO2. The strength training, no surprise, the strength training group had a very significant increase in strength. And notice what happened to the control group in both of these groups. So again, these are in the hospital, patients coming in, treated for an exacerbation, and what happens to the aerobic capacity of the control group? It went down. You would think they're getting better, right? They're getting IV antibiotics, they're there to get better. Well, we send them home and they have a lower aerobic capacity than they did to start with. Now, not statistically significant decrease, but nonetheless, it definitely wasn't any better. And the same for their strength. Their strength was lower when they left the hospital. So we're bringing folks in to treat them, but without exercise in the hospital, we're sending them home at a little bit lower level than they showed up in the first place. Santa Sosa's study had no change in body composition. So there was no improvement, no decrement in body mass during the study. So they were looking at both body mass in kilograms as well as fat-free mass. No significant changes there. However, there was significant improvement in the exercise group in both peak VO2 as well as peripheral muscle strength. Again, this study included all the participants got aerobic and resistance exercise training. And a pretty substantial kind of increase in strength as well as peak VO2. Following up their second study, this is the one that included inspiratory muscle training. So again, no change in body mass in either group, no change, no significant, statistically significant change, but it looked like there was definitely a trend towards an increase in fat-free mass in the exercise group. And then likewise, they did see, again, an improvement in aerobic capacity as well as strength in the exercise group. And then our final study really didn't find any significant changes. You'll remember this was a study that was kind of the least descriptive in terms of the intervention, so we're not sure kind of what all went on in terms of the intervention, but the outcomes were pretty unequivocal between these in terms of the differences between the exercise group and the control group. And so no significant differences related to body composition and or physiologic outcomes. And so we did rate these studies using the Pater scale. The Pater scale is kind of a 0 to 10 scale, kind of a quality rating scale. It's kind of 8 to 10, kind of being a really high quality study. Kind of 6 to 7, kind of being kind of moderate quality studies. And it's often difficult to do these. Obviously, when you're providing a physical therapy intervention, with the exception of the inspiratory muscle training where you can give a sham intervention, it's hard to blind the subjects to the intervention. Two of the studies did have blinded assessors, which made their scores a little bit higher. So there are some methodological problems with trying to do physical therapy, behavioral interventions, and kind of blinding everybody that's involved. So in conclusion, no randomized controlled trials have evaluated the effects of an exercise intervention on the nutritional status in adults with cystic fibrosis. And the trials that did evaluate exercise and nutritional status in children with cystic fibrosis only included those with either normal or low body mass. And we know now with most of our patients going on highly effective modulator therapies that they are gaining weight. And now kind of being overweight and obese is becoming a concern. However, we did find that neither aerobic exercise training nor resistance training had any negative impact on decrease in body mass or body mass index. In fact, it looks like resistance training has the effect of increasing lean body mass. And so in addition to improving kind of body composition with resistance training, it also improves peripheral and the data that it didn't show, it also improved inspiratory muscle strength in folks that did inspiratory muscle training. And aerobic exercise training improves peak aerobic capacity, which again is kind of an independent predictor of mortality. So in conclusion to kind of wrap things up and talk about future directions, exercise is not detrimental to nutritional status. So if you have patients that are kind of worried about exercise and losing weight, it's not, there's no evidence that that's going to happen. Fortunately, our weights on our patients are going up now, and we have fewer and fewer patients that are in the kind of lower weight category. Exercise and physical activity recommendations, therefore, should include both aerobic and resistance exercise to improve aerobic capacity, to improve body composition, and to improve strength. And in these studies, there were multiple ones that used DEXA and skin folds to look at body composition. And so now in the clinics, we're primarily just looking at body mass, looking at body mass index. And I think we need to look at other alternatives to those two. So we need to be using, bioelectrical impedance, DEXA, skin fold, circumferential measurements, other items to be looking at body composition so that we can help patients recognize that, yes, you are maybe gaining some weight with this exercise, but you're gaining fat-free mass, you're losing fat mass. So the fact that you're gaining weight might be a plus as opposed to a negative. So future research, we need to look at the effects of exercise in adults with cystic fibrosis. So we already have kind of a planned kind of analysis to look at non-randomized controlled trials of adults, exercise studies in adults. And we also need to look at the effects of exercise in children and adults that are overweight and obese to see, does exercise kind of moderate the rise in kind of overweight and the percentage of our patients that are now kind of overweight and obese. And so here are kind of references, and I just want to kind of acknowledge the rest of my co-authors on this particular paper. Dr. Nicholson and Crick, Dr. Crick's our associate clinic director. Dr. Nicholson was a resident in pulmonary medicine. Dr. Bailey is our clinic dietitian, and Najla is a physiotherapist and a PhD student in our department. And just kind of leave you with the idea that exercise is medicine. It has beneficial effects and really no detrimental effects. So we should prescribe exercise for everybody. And while I have this last minute here, just a plug, if your patients are interested in exercise, thanks to the graciousness of the Cystic Fibrosis Foundation, BEAM is an online platform, kind of a virtual exercise platform for patients with cystic fibrosis. So it's a kind of a virtual gym. They have kind of in-person and kind of on-demand classes for patients with cystic fibrosis. All of the instructors with BEAM, and BEAM's not paying me to say this, by the way, I'm just a big advocate. All of the instructors are either physiotherapists, physical therapists with a kind of expertise in cystic fibrosis, or they're patients with cystic fibrosis that are personal trainers, yoga instructors. So everybody has kind of expertise in exercise and cystic fibrosis. So they offer resistance training, aerobic training, airway clearance training. So there's lots of options available for them. So with that, I'll take any questions you have.
Does anybody have any questions?
Just wanted to ask whether any of the studies reported caloric intake. I'm not aware of the advanced studies.
No, none of them looked at dietary intake. But it's a good point. I think, as we go forward, especially when we're looking at, in the future, folks that are kind of overweight or obese and exercising, I think we need to look at not just energy expenditure, but energy intake too. So we need kind of a multidisciplinary kind of approach. No, so these, the methods that they used for these, they weren't tailored kind of specifically to minimize kind of caloric expenditure. So they were, all of the aerobic interventions were pretty much in line with the guidelines for healthy adults in terms of the intensity and duration. And in fact, they were probably kind of on the lower end. They certainly weren't long enough that you would expect. They didn't kind of cross the threshold you would expect to lose weight. if you were trying to lose weight. But again, the reason we were prompted to do this study in the first place was, we had kind of multiple patients in our clinic that were kind of reluctant to exercise because they were afraid of losing weight.
You referred to respiratory muscle training, or you said some of the studies had that. I thought that wasn't really beneficial for cystic fibrosis patients. Is that like a standard in those studies with those children?
Yeah, it's not a standard, and there was one study, and I didn't report the results on it, but I'm not sure exactly why. They basically kind of did the same study twice, and in the second time they did the iteration of the study, they decided to add in inspiratory muscle training. We actually did a review paper a couple years ago on inspiratory muscle training, and kind of part of the problem is studies that do inspiratory muscle training. They just kind of throw it at everybody without looking at folks that have impaired inspiratory muscle strength. And so what we found was that in the populations that, in the patients that had low-end inspiratory muscle strength to start with, inspiratory muscle strength seemed to benefit them in terms of their exercise capacity. But if you had normal inspiratory muscle strength to start with, adding that didn't kind of improve exercise capacity. So I think there's a lot of kind of selection bias there. So you need the, need the right intervention for the right problem. Yeah, so the main one is looking at their maximal inspiratory pressure, or sometimes referred to as the NIF. Like pulmonary function, it's kind of, it's less dependent on height. I think the parameters that primarily go into kind of predicting what somebody's maximal inspiratory pressure should be is basically age and sex, and not necessarily height and weight. But yeah, so kind of looking at thresholds there, and then there is a lower limit of normal for that. So there's kind of a range of what normal values would be.
Any further questions?
All right, well, thank you.
All right, thank you. Okay, our next but not least speaker is Dr. Felix Ratchen. He is a professor of pediatrics and the division head of pediatric respiratory medicine at the Hospital for Sick Children in Toronto. Dr. Ratchen is an international leader in lung clearance index, and he is going to present to us LCI, moving a research tool into the clinic.
So thank you for staying around for the last talk of the session and the last talk of the conference, at least for this session. So I think what I will try to do is to take you along the path of what we learned with LCI so far, and you heard quite a bit about this during this meeting, also from studies like PROMISE and Simplify. So I'm not going to talk so much about the data that you've seen in this meeting, but more about the steps of what we learned through interventional studies, what we learned from observational studies, and how we can move this into the clinic in the future, which is, I think, the step that we need to take. Now, so if we look at outcome measures for cystic fibrosis, there are a number of things that we can look at, and usually we look at biological surrogate markers of survival that help us to link those, and especially in clinical trials, that's very important. And lung function, such as FEV1, has been our workhorse for decades. And but there are a number of other outcomes, and I'm not going to go into all these other outcomes, but I'm just going to focus on the problems that we have with FEV1 these days. So this is the old data that were actually generated by Mary Corey at our center in Toronto quite a while ago, looking at how FEV1 at any given level predicts subsequent survival. So it actually works pretty well in this sense. So if you have limitations in your FEV1, then its linkage to survival and its utilization as an outcome measure is quite strong. But the reality is things have changed. And so we are really victims of our success in terms of treating CF patients, which is a great thing. So it's good that our patients are so much better. And so in the past we said, well, that happens in young children, so lung function based on spirometry is now in the normal range for most children. But now that's also happening more and more for adult patients. So it becomes, while we thought in the past, okay, we need another outcome measure for children, and we're still pretty okay with the adults, that's also changing. If we look at some of the other outcome measures, such as exacerbations, you all know that by now with the highly effective modulators, those have become quite rare events. And we have used symptom scores in clinical trials, but one of the problems with the symptom scores is they have the ceiling effect. That means many of the patients now report no or very limited symptoms, and then you cannot expect any improvement over time if you look at that. And sweat chloride is used in these interventional studies for CFTR modulators, but the problem is there's no close link between how you respond in your sweat chloride and your clinical response. It's nice for the patients and families to see that their sweat chloride goes down, but it doesn't mean that it translates one-to-one in lung function improvements. And so this is not just an issue for clinical trials, so it certainly is challenging for clinical trials. And Patrick Flume talked about this today in one of the symposiums and what the challenges that we have moving forward with some of the clinical trial assessments. But we also need that in the clinic, right? How do we decide when to start or stop a treatment when we can't measure success or failure easily with a measure such as FEV1? What measure helps us decide whether to treat intermittent symptoms? And especially with the highly effective modulators, the question will come up more and more. Should we be as aggressive in terms of initiating treatments with antibiotics and other things as we have been in the past? But then the other question comes up, how easy is it actually to implement a new measure into clinical care? And for LCI, there are some challenges, and I'll talk you through this and also what we plan to do in the future to hopefully overcome this. So just take a step. I want to take a step back and tell you about why is a measure like the lung clearance index actually helpful. We know that early lung disease is associated with regional mucus plugging. So you would expect in a diffuse lung disease like CF that it's happening all over the lung in a similar manner, but the reality is actually quite different. And the distribution of the disease is non-homogeneous. And therefore, a global measure of lung function, such as FEV1, does not really capture that well. And that has been well demonstrated with some of the imaging studies using CT and showing disease progression while FEV1 is stable. And we know from some of the initial studies and also from the later studies that the multiple breath washout test is more sensitive to these regional abnormalities. And just to give you an example for one of my patients, so this is a CT scan, and most of the lung looks pretty normal. And this patient had an FEV1 of 105%. But so you would certainly not argue with me that this region of the lung is abnormal, and you don't capture that with a measure like such as FEV1. So how do we perform the multiple breath washout test? You can use different tracer gases to do this. SF6 has been used, especially in infants, where using 100% oxygen may change their breathing pattern. But mostly now people use nitrogen washout, where you basically wash out the resident nitrogen from the lungs. And it's a very simple technique, and this is just how do you do it in an infant or a preschool child, but the principle is the same throughout all age groups. And so basically what you do is you have the patient then inhale 100% oxygen, and over time that washes out the nitrogen of the lungs. And the longer it takes to wash that out, the more mucus plugging you have in the lungs. And this is basically what LCI quantifies. So in technical terms, it's how many FRCs or how many turnovers of their lung volumes it takes to reduce a tracer gas to 1/40 of the starting concentration. This is the LCI 2.5. There are other measures that you can use, but this is the most commonly used and has been quite useful in clinical studies. And it's different from what we'll be used to for FE1. So higher values of LCIs are bad. And lower LCI means that your lungs are more efficient in washing out this gas. And just to highlight that it needs the multiple breath, these are two washout curves from healthy individuals and from one with lung disease. And you can see over the first couple of breaths, and you plotted out the individual breaths, and for the first part of it, they look exactly the same. So if you would cut this off early on, you wouldn't see a difference between health and disease. But then the longer you show, the more these two differentiate. And so this is why you need a bit of a longer washout to make this test useful, which also means that the test takes a little bit longer, which is the downside of the test on the other side. And we know from some of the earlier work, where this was work done in London in the UK, is that if you look at LCI and compare it to FEV1 using Z-scores or Z-scores, and basically you have this group of patients that have a normal FEV1 but an abnormal LCI, and in percentages overall, that before the highly effective modulator era, about 2/3 of patients in the school age group had abnormal LCI, even though the mean FEV1 was in the 90 to 100% range. And it's important also to know that LCI does predict how your lung function will end up with other measures later on, and they showed this in the same studies in the UK, that not only is there a correlation between where your LCI is in the preschool to where it is at school age, but also there's a relationship between your preschool LCI and your FEV1 later on. So how has that been performed in clinical trials? And you've seen some of those data, so I'm just going to go through this relatively quickly. And we've done a number of studies looking at this with interventions that we know have some efficacy in CF, such as hypertonic saline and DONAS alpha, which we now have done the stopping trials with. But the first modulator study that we did was with ivacaftor. In this case, we specifically looked for patients with good lung function, so an FEV1 over 90%. These were patients with the G551D mutation, so eligible for ivacaftor in terms of the potential of improving their lung function. They had to have an abnormal LCI, and they had to have an FEV1 above 90% predicted. And we included patients that were 6 years or older. And what we did is basically a crossover trial where we, over a period of 4 weeks, patients were either treated with ivacaftor or placebo and then switched over to the other arm. And if you look at the data overall, in the placebo group, there was a little bit of an increase of the LCI over time. And in the blue line that you see on the slide, there was a decrease, and the effect size here was about 2 LCI units. But if we look for effect sizes and compare different studies, then we have to think about the different tracer gases that were used and the different versions of the software. So it has become a bit confusing how to interpret these different data. How does that look for somewhat less impressive interventions such as lumacaftor, ivacaftor, which we now have moved away from as a therapy? But this is the first time this was actually used in a phase 3 trial of a regulatory study, and in patients 6 to 11 years of age. And you can see in the placebo group there was basically no change in LCI over time, but in the treated group there was a decrease in LCI that was maintained over time. And we've seen this from numerous modulator studies now, that we can see this effect on LCI of the intervention. We also used this in preschool studies, and the SHIP study is one of the studies that we used looking at hypertonic saline over a period of a year. And the comparator group was isotonic saline. We didn't call it a placebo-controlled trial because isotonic saline might actually have some efficacy, and all of these patients also received inhaled albuterol or salbutamol. And we did see a treatment effect on LCI in this as well, and we now have data from the SHIP CT study showing that what we see in LCI is also reflected in improvements of mucus plugging that you do see on CT scanning. And just to put this in context, from the PROSPECT study, which was an observational study similar to the PROMISE study of patients being on lumacaftor, ivacaftor, or Orkambi. And so in the upper part, you see that the changes in FEV1 that were seen during the study, which were not very impressive in terms of the improvements. And in the lower, in the bluish line, you see the effects on LCI. And if you just break this down, and then with LCI, we saw 3 times the effect in percent change compared to what you see with FEV1. And that's pretty consistent through studies. So as an outcome for clinical studies, it's now pretty established. But how do we use that for our day-to-day management of patients? And for that, the observational studies are probably a bit more useful in terms of the information that they gave us. And the first study that we did in this sense was a preschool study to see, okay, how can we use that to monitor disease progression over time in this age group where we don't really have tools otherwise. So this was the study that was funded by NHLBI, and what we were looking at was the natural progression, but also the variability of the test, because that's also important to understand if you want to see, is a change that you observe actually relevant, or is it just within the wobble of the data and the variability of the data? And we wanted to see how does LCI change over time in children with CF, but also in healthy children. So comparing it to healthy children is very important if you want to understand those changes. And we assess that at time point that can also be used for clinical trials. And overall, this is what we saw for LCI on the left-hand side and for FEV1 on the right-hand side. We also did preschool spirometry in this study, which was a 3-center study with 2 centers in the US and our center in Canada. And what we saw over time is that the LCI actually increased, this dotted line in the CF group over a 1-year period, and did not change in the healthy kids. And for FEV1, we did not see a signal. So that just supported the concept that is more sensitive in monitoring patients over time. How does that behave during symptomatic episodes? Because this is one of the areas where we might need to decide whether to initiate a treatment or not. So we looked at patients who just had upper airway symptoms, so basically a runny nose, those that had cough, or those that were diagnosed by their physician or caretaker to have a pulmonary exacerbation, which of course wasn't the case for the healthy population. So for the healthies, we only have the upper airway symptoms and the cough in these smaller symbols. And what you can see here is that for healthy kids, when they have upper airway symptoms or a cough, so basically a viral infection, there is no change in LCI. But in the CF population, there's no change with just upper airway symptoms, but if they have a cough, it is associated with worsening of LCI. And we also looked at this in a different way to see, can this help us to track patients over time and see how they actually improve over time. And these are 2 groups of patients, so symptomatic patients, that either were treated with antibiotics by the physician based on the diagnosis of having a pulmonary exacerbation in this, with these round symbols. But then in blue, we had these groups, this group of patients that were somewhat symptomatic, but the physician felt this is probably not bad enough to initiate any kind of treatment. And interestingly enough, so the LCI was somewhat lower, but higher than in the control group for those that were not treated. But when we followed them up over time, they still had an elevated LCI. So you wonder whether those patients actually should have been treated in order to make sure that they come back to their baseline. And we've seen similar data in the school age group, which we subsequently studied. And this has been published 2 years ago in the Blue Journal. And again, with patients with symptoms that are treated with antibiotics, the FEV1 results are on the upper panel, and the LCI results are on the lower panel. So those where the physicians decided to treat have somewhat worse lung function in both measures, which is not surprising because we use FEV1 in clinical decision making, but in the study we didn't use LCI for clinical decision making. But at follow-up, there's still this deficit that you see in both of these groups. And so which makes you wonder is, have these exacerbations been treated aggressively enough? And when we looked at this in terms of returning to baseline after an acute respiratory event, we could pick up, with LCI, we could pick up more events that did not return to baseline. So which again raises the question, should we use that as a monitoring tool for patients that have acute respiratory events? Okay, so In terms of the variability, most of the studies have reported a higher variability of LCI versus FEV1. But one of the problems is if you have a more sensitive tool, it may just pick up situations where patients actually have symptoms versus other measures such as FEV1. And so for our observational studies, we looked back and to every visit that those patients came in and retrospectively then defined those visits as being either associated with a clinical relevant change that could be picked up versus being a stable visit. And if you do that, then the variability of LCI is actually pretty low and very similar to FEV1. And so because most of the what is considered to be variability is actually signal. Okay, but with that, what do we still need to really move this into the clinic? I think we have quite a bit of evidence that it might be a good tool. But for clinical implementation, at least in North America, we need a number of things. And some European centers have already implemented that into their clinic. But in the US, certainly, we need FDA approval for the MBW device, but also reimbursement for the MBW test, and that's more of a challenge. And we have to answer a couple of questions. Can we use different devices in clinical care? And we have to prove that if we use it in clinical care, is there actually evidence that it changes the outcome of the patients? And that's actually a study that we're currently in the planning phase for, where we will use LCI in a group of patients and then not use LCI in a parallel group and see how it affects decision-making, clinical decision-making, but then also how does it affect outcomes of these patients over time. It's a bit of a challenging study to do, but we hope we can pull it off and then we can get it started in the next year or so. But what do you need at your center in order to implement LCI? These are basically the basic needs. You have to have 1 or 2 trained operators, depending on the age group. For preschoolers, you usually need 2 people, just because it's a bit more challenging to do in preschoolers. You need a validated MBW device using either nitrogen or SF6 as a tracer gas. And most importantly, you need a quiet environment to allow the patient to be distracted, and we usually use video distraction for that. And you need time, and that's something that's not always available in the clinic. So and with that, this is another washout that was created in British Columbia. I think it was last year, where one of the highways was washed away. And I left some links to our National Resource Center for LCI that we have in Toronto, but also for our MBW Center that you can look up. Thank you very much.
Do we have any questions?
Any energy for questions? Yes.
You mentioned on your last slide that I think the last point was time. So what's kind of the range of time to do an LCI?
Yeah, it certainly depends on the severity of lung disease. So the good news is the younger the kid, the shorter it takes, and also the less lung disease you have, the shorter it is. But then the younger kids need more distraction and more time, and that. So usually it takes about half an hour to do the test overall, because you need to do multiple tests. You have to do it usually 3 times to make sure that you get adequate data. So it is certainly longer than spirometry. So it's and so that's also one of the questions: is should this be something that should be done at every clinic visit? Should we just do it once a year as an annual assessment, and then maybe at times when patients are worsening in terms of the clinical status, because running this in a full set clinic on a regular basis is very challenging. So, I mean, we do a lot of research with that, but in my clinic I have 3 teams doing this in parallel, doing the clinic, and that's not realistic for a broader population of CF centers. So we need to make sure that we define this well in terms of when do we actually need this test and when can we work with other tests. Yep. Yeah, I think that this is a good question, and I think the sweet spot for the technology is certainly those patients where we don't have other methodologies that are available. So I think that clinical utility will be mostly in that group. This group will grow over time with the highly effective modulators, and you saw some of these slides in the last plenary today. But this is really the group. I mean, if you have a reduced FEV1, FEV1 works pretty good as a tool in the clinic. And this might be one way that we can reduce the number of patients in which we do these tests. But it doesn't mean that it can't have a utility in patients with somewhat more advanced disease. But in those patients, we have other tools. One of the things that we found in some of our observational studies is that you can pick up signal with one tool that you don't pick up with the other. So FEV1 and LCI don't always tell you the same story, but there it becomes more complicated. And I think for practical reasons, I think the strategy of focusing on those with relatively normal FEV1 might be the best one. Yes? Yeah, that's a good question. So how often, when do you start doing this? So in unsedated children, we usually, you can start at 2.5 to 3 years of age. Under 3 years, the yield is not always good, and you have to train them a little bit until they are going to be able to do it. You can do it under sedation in any age group. Again, the nitrogen washout is not ideal with the young infants, so from 6 months onwards, it is doable in this age group. And can you please repeat your second question? Yeah, no, I think it's probably, and we have used some of our observational studies to actually help us. What kind of information do we miss if we do it every 6 months versus every 3 months versus once a year? And you lose a little bit of information, but it's not enormous. And so in stable patients, it's probably going to be fine to just do it in longer time intervals and likely do it once a year. And then it might also change with younger and younger patients going on highly effective modulators because they are expected to be more stable. But you certainly can get surprises in patients, and we've seen this in some patients that clinically looked fine, and then we measure their LCI and we see it's quite abnormal, and then you pick up bad bacteria and so on. So there are certainly situations where you have to be on high alert for that. But as a tool, I think the realistic implementation will be in broader time intervals. Yes. Yeah, so that's a good question again. So I think it can be helpful to demonstrate to patients that there is abnormality. Similarly, that you can use imaging to say, okay, while your lung function might be normal, your imaging, you actually have significant changes on imaging. So yes, it can be helpful in that sense. Of course, imaging is sometimes easier to tell the story because you can pinpoint the abnormalities, and the number is always more difficult to digest. But I think it is a message to patients and families if you say, look, here's an abnormal. It's not normal. It's not everything is fine. And that's been a bit of a problem of us using FE1 as our main tool over the last couple of years because we've been telling patients, okay, your FE1 is fine and normal, everything is good, go home. And that may not always be the case, and because we didn't use the tools that are sensitive enough.
I have a question. Would you recommend the adult center using the LCI as well?
I think we're not quite at the point where we where we recommend this as a general tool in adult centers. But if you look at the trend over time, I think you guys have to do this and at some point. You have to learn it, and because you will have that population with normal lung function, and where you need a more sensitive tool. You had a question, right? Which is Vancouver, okay. Okay.
In Naomi's presentation, she talked about using LCI as an evaluation tool for airway clearance techniques. I'm curious about, so are you aware of any studies that have looked at LCI post-airway clearance and/or post an acute exercise, palliative exercise?
Yeah, so they have a number of studies that have looked at this and haven't necessarily found a clear signal. And one of the problems is if you do airway clearance and you don't always see an immediate effect, and we've seen this in previous studies with FEU1 as well, that there isn't necessarily an immediate effect if you move mucus around. And one of the issues that we actually have a small study where we looked at MRI imaging versus LCI and in patients that actually had worsening of LCI over time with maneuvers. And you can see that they shift their mucus, and with shifting the mucus, you open up areas that are poorly ventilated, and that can actually worsen your LCI. And for the short-term studies for airway clearance, I don't think LCI is actually the ideal measurement, and that has been shown in a number of studies. There are some data that I shouldn't probably not talk about them because they're not published, but there's some MRI data and looking at ventilation imaging that are quite promising in terms of looking this as one of the technologies that might pick up short-term changes with airway clearance. I think you're all ready for a drink, huh?
Yeah.
I am as well. Okay.
Thank you.
Thank you.